Okay, so you've probably seen this trend. It's kind of everywhere, right? Social media, wellness blogs,
Oh yeah, mouth taping.
mouth taping, exactly, or these other little gadgets to keep your mouth shut while you sleep.
And it's pitched as this, like, silver bullet. Better sleep, better breathing.
Yeah, this universal fix.
Yeah,
The basic idea seems to be, look, stop mouth breathing. It's always better for you. Full stop.
right. That's the conventional wisdom.
But what if it's not quite that simple? What if that story's missing something?
Well, that's exactly what we're diving into today.
We're looking at this really fascinating study from JAMA Alluring Oncology Head and Neck Surgery, just came out in 2024. Yang and colleagues.
It throws a bit of a curveball at that whole idea.
It really does. It shows a much more, well, nuanced picture.
Yeah, and what's so important about this, I think, is that it forces us to really re-examine that common belief.
So what's our mission today?
Our mission is really to unpack the, let's say, complex relationship between mouth breathing, airway obstruction, and obstructive sleep apnea,
Right.
OSA. And you're going to find out why, for some people, actually closing the mouth,
Yeah.
it might make their breathing worse during sleep.
Worse. Wow.
Yeah, it really points towards needing more personalized ways to treat OSA. And this study, it's a non-randomized trial, but it gives us some really clear mechanical insights. It helps understand why you see these different results in different people.
Okay, let's unpack that because the general vibe, the thing we all kind of hear, is that mouth breathing is, well, abnormal.
That's the label it often gets, yeah.
And it's been linked pretty strongly to, like, higher airway resistance, more severe OSA.
Right, there's research backing that up.
Definitely. I remember Fitzpatrick and colleagues way back in 2003, they showed healthy people forced to mouth breathe. Their AHI, the apnea index, just shut up.
Yeah, from like normal to severe levels.
Exactly. And more recently, Suzuki et al., I think 2020, found higher resistance with mouth breathing in actual OSA patients using fluid dynamics modeling.
So the story seemed pretty consistent. Mouth breathing bad, stop it.
Right. That was the takeaway.
And that's precisely the assumption this new study went after. They asked, okay, hold on. What if mouth breathing isn't always the villain? What if, for some folks, it's actually essential, like a necessary detour,
A detour. How so?
like a backup route,
Yeah.
to get air around an obstruction, maybe in the nose or higher up in the airway, like the velopharynx, the soft palate area.
Ah, okay. So if the main road is blocked.
You take the side street. And this was a really important clinical question nobody could really pin down. Could forcing the mouth shut actually backfire? Could it increase resistance and be harmful for those specific people who rely on that mouth route?
So how did they figure this out? They used a pretty advanced setup, right?
DICE? Yeah, drug-induced sleep endoscopy.
Why was that specific technique so important here?
Well, because it lets you simulate sleep in a controlled setting, like an operating room.
Okay.
So you can actually see and measure what's happening with airflow in real time under conditions that are really close to natural sleep apnea events.
Yeah.
Way more informative than just measuring someone awake.
Gotcha. And for the actual measurements, they had this special mask.
Right, a tight-fitting aeronasal mask, but it was partitioned.
Partitioned, meaning?
It kept the nose and mouth separate, basically. And it was hooked up to two different airflow meters, pneumotocometers.
Ah, so they could measure nasal airflow and oral airflow completely independently.
Exactly.
Yeah.
At the same time. So you get a super clear picture of where the air is actually going or trying to go. It's a really robust method.
And how did they actually simulate closing the mouth?
It was actually quite clever. They applied gentle pressure just under the chin, the mentum.
Okay.
Just enough to bring the teeth together. And they do this on alternating breaths.
Oh, smart. So breath open, breath closed, breath open, breath closed.
Right. It allowed for a really quick comparison, open versus closed, without waking the patient up. You get an immediate physiological snapshot of the impact.
Okay, so what did they find overall, looking at all 54 patients together?
Well, initially looking at the average across everyone, mouth closure did seem to help.
It did?
Yeah, on average, total airflow increased by about 27.8 percentage points, which is roughly 1.0 liter per minute more air,
And where did that extra air come from?
mostly through the nose. Nasal flow went up when the mouth was closed.
Okay, so at that high level, it kind of supports the old idea, right? Close the mouth, breathe better through the nose.
Exactly. The average seemed to fit the narrative.
But averages, they can hide a lot, can't they? What happened when they looked closer?
This is where it gets really interesting. They found huge differences between patients, significant heterogeneity.
Okay.
So what they did was group the patients based on how much they were already mouth-breathing at baseline before they did anything.
Right, based on their starting point.
They split them into 3 groups, quantiles. Quantile 1 had almost no mouth-breathing to start with, less than 0.05 liters per minute.
Okay, the non-mouth breathers, basically. What happened to them?
For them, closing the mouth. Pretty much no effect. Airflow changed by maybe 0.9 liters per minute, statistically insignificant.
Makes sense. They weren't using their mouth much anyway.
Exactly.
Okay.
Then you had quantile 2. These folks had moderate mouth breathing, somewhere between 0.05 and 2.2 liters per minute.
The middle group.
Right. And for them, mouth closure was definitely beneficial. Airflow went up by a solid 2.0 liters per minute.
So this is the group that fits the conventional wisdom.
Perfectly. Close their mouth, they breathe better. No surprise there.
Okay, but then there's the third group. This is where it gets wild, isn't it?
This is the kicker.
What?
Quantile 3. These were the patients with the highest amount of mouth breathing at the start, over 2.2 liters per minute.
And for them?
For them, closing the mouth was actually bad. It was detrimental. Their airflow decreased by an average of negative 1.9 liters per minute.
Wow, decrease. So for about a quarter of the patients in this study?
Roughly, yeah. About a quarter of them. Closing their mouth made their breathing objectively worse.
That's a really big finding. It just blows up the one-size-fits-all idea.
Completely.
And what's fascinating is how they connected this back to why? To the anatomy.
Yes. They looked at the site of obstruction during the dyes, and they found a strong link.
What was the link?
Patients with velopharyngeal obstruction, that's blockage, at the soft palate, like we mentioned, which is upstream from the mouth route.
Okay.
Those patients were much more likely to be in that high mouth-breathing group, quantile 3, and they were the ones who had that negative response when their mouth was closed.
Ah, so it confirms the hypothesis.
It really does.
Yeah.
It provides solid evidence that for them, mouth breathing wasn't the problem. It was the solution, a necessary bypass for that upstream blockage.
That makes so much sense now. But there was also a positive finding for a different group, wasn't there? Something about lateral walls.
Yes, another really interesting subgroup. Patients whose main issue was oropharyngeal lateral wall collapse, the sides of their throat collapsing inwards.
Okay.
They actually responded best to mouth closure. Their airflow increased significantly by about 2.3 liters per minute.
More than the average increase.
Yeah, quite a bit more.
So what does that suggest is happening there?
Well, the thinking is that closing the mouth might physically pull on those tissues, maybe stabilizing or even widening the airway laterally. It might sort of splint it open from the inside.
Huh. Interesting mechanism.
Very. And potentially quite important.
So let's connect this to the bigger picture. What does this all mean for treating sleep apnea for people dealing with this day to day?
Well, the biggest implication is caution. Extreme caution, maybe, when thinking about applying mouth closure therapies like tape or chin straps universally.
Because it could backfire.
Exactly. As we saw for maybe a quarter of patients, maybe more, maybe less in the general population, but a significant chunk. It could actually make their breathing obstruction worse.
Which underscores the need for personalization, right?
Absolutely. It screams personalization.
And why should you, listening right now, care about this? Well, if you're someone using or thinking about using mouth tape or a chin strap, and you happen to be in that group where mouth breathing is actually helping you compensate, then that simple, seemingly harmless intervention could be ineffective or worse, actually harmful.
It really highlights that you need to understand your specific pattern. What's causing your OSA? Where's the obstruction?
Your individual anatomy and breathing pattern are key.
Totally. And that other finding about the lateral wall collapse patients doing well, that's also pretty significant clinically.
Why specifically?
Because that group, patients with lateral wall collapse, often don't respond great to other common non-CPAP treatments. Things like oral appliances or even hypoglossal nerve stimulation. Success rates can be lower.
Ah, I see. So mouth closure.
Mouth closure, maybe used strategically, perhaps even combined with other therapies, could potentially offer a real benefit for this specific, often hard-to-treat group.
Right.
It might enhance what they're already trying.
That's a hopeful angle. Now, we should probably touch on limitations just for a balanced view.
Of course. Every study has them.
They use propofol for the dyes, right? That's not exactly natural sleep.
True. Propofol anesthesia isn't identical to natural sleep stages, although it's the standard for DUS, and they looked at the immediate, acute effects of mouth closure, not what happens night after night over months or years.
Right. So long-term outcomes aren't addressed here.
Correct.
Yeah.
But the mechanism they identified, that compensatory mouth breathing that's physiologically very sound. It makes sense. So even with the limitations, the insights about why some people mouth breathe and why stopping it can be bad, those are really valuable.
Definitely feels like a big piece of the puzzle.
I think so. So if we boil it down, the core takeaway here is that popular idea that nasal breathing is just always better than mouth breathing.
Yeah.
We need to seriously rethink that, especially in the context of OSA. For a lot of people with obstructions, mouth breathing isn't some bad habit. It's a vital compensation.
It's a workaround their body has found.
Precisely, which, raises a pretty important question.
Okay, leave us with that question. What should we be thinking about?
Given what we've learned today, if you, or maybe someone you know, is thinking about trying mouth tape or some other mouth closure thing for sleep, how crucial does understanding your own individual breathing pattern, maybe even your specific site of obstruction, become before you jump into that?
Right. It's not just plug and play. What new questions does this raise about what truly personalized sleep medicine should look like?
Exactly. How do we get better at figuring out who belongs to which group before we try interventions? That's the challenge.